A very good morning to all of you in the audience. My name is Arosha Disanayak. I'm the president of the Ceylon College of Physicians, and welcome to the June edition of the Young Physicians Forum, as to be followed by the college lecture. As you all know, this is a platform that we offer to our the newest members, our associate members who are at senior registrar level, to hone their presentation skills, the ability to perform in front of an audience, discuss an erudite topic, and help progress their career. Then, of course, we will have the college lecture followed by that. And for the college lecture, this is going to be our month of neurology, the month of June. And I'm privileged to have Dr. Gamini Pathirana, consultant neurologist and the immediate past president of the Association of Neurologists of Sri Lanka, also joining this audience. So he will be part of the college lecture as well. And then today we have two very bright senior registrars joining us to speak to you. Dr. Asiri Gunasekara, he is a trainee cardiologist, and Dr. Gatika Kodituaku, he's a trainee nephrologist. And to start off, may I invite Dr. Asiri Gunasekara. Asiri Gunasekara is a senior registrar in cardiology at the National Hospital in Kandy, and he's going to talk to us about a difficult area in our diagnosis and management protocol. He's going to speak to us about establishing a diagnosis as well as understanding the pathophysiology of heart failure with preserved ejection fraction or diastolic failure. We are all very comfortable with systolic heart failure, but we are trying to understand diastolic heart failure. So I'm sure this lecture will help us a lot in the process. May I invite Dr. Gunasekara to make his presentation. It's a pleasure to have you. Thank you very much.
Good morning, everyone. Thank you, sir. I would like to thank CCP for giving me the opportunity to present at this forum. And I would like to welcome all senior consultants and colleagues for a lively discussion regarding heart failure with preserved ejection fraction. So my topic for today is heart failure with preserved ejection fraction, diastolic heart failure, understanding the pathophysiology and approaching the diagnosis. So these are my objectives. Why is it timely to discuss heart failure with preserved ejection fraction? And is it an important clinical problem? Does it cause substantial morbidity and mortality? Is it a global burden? What is the pathophysiology? Who are the key players in this complex disease pathogenesis? How do the cardiac mechanics change in HFpEF? And how to recognize HFpEF on echo? And why is it different from heart failure with reduced ejection fraction and heart failure with mildly reduced ejection fraction? Are there any encouraging new therapies for these patients? After years and years of modest results from clinical trials, are there any change? Are there any new evidence? So with that in mind, I would like to go to a clinical scenario. I am sure all of you have seen this patient. My patient is a 72 years old female with type 2 diabetes, dyslipidemia, hypertension, chronic kidney disease, and obstructive sleep apnea. She is retired, lives with her daughter. Patient presents with characteristic symptoms of heart failure with exertional dyspnea and orthopnea, which was of gradual onset. There was no angina. Examination revealed an obese female with a BMI of 37 kilograms per square meter with a blood pressure of 170 by 104. She had characteristic signs of heart failure as well, with raised venous pressures, creps on lung bases, and bilateral pitting ankle edema. Patient was in sinus rhythm. 2D echocardiogram revealed an ejection fraction of 50. There were concentric LVH and dilated left atrium. Patient's BNP level was 275. I admit it is higher than the upper limit of normal. However, I would also like to note that this level is less than what we expect depending on her clinical history. For the discussion, we will assume that other differential diagnoses were excluded. This is a drug list. Please look at this drug list and try to imagine what changes would you like to make. After making a diagnosis, I tried to recount her diagnosis to my patient, and she asked me some important questions. She asked me, why is my heart failing if it is pumping well? Is it because of my weight? I have heard of similar heart disease in young people with several members of the same family dying. Surely I don't have that, do I? Am I at risk of death due to my heart disease? Which medicines would you recommend for my breathlessness? Are these medications helping my heart in long term? This is a very exciting time to discuss heart failure with preserved ejection fraction. Globally, around 1 to 3% of adult population has heart failure. Among them, HFpEF is the most common type, accounting for around 50% of these cases. In contrast to HFrEF, where its prevalence is on the decline, HFpEF prevalence is on the rise. Why is that? That's because of worldwide population aging, as well as increasing prevalence of conditions associated with the development of HFpEF, most notably obesity. HFpEF patients represent the largest area of unmet need for therapies in cardiology. These patients have debilitating symptoms, physical limitations, as well as poor quality of life. They have a substantial risk of hospitalization and mortality when compared to normal people. However, their risk for mortality is less than that of heart failure with reduced ejection fraction patients. These are a heterogeneous group of patients. Their complex pathophysiology is complex. However, obesity-related HFpEF is the most common type. And there is a surprising lack of disease-modifying therapies for HFpEF. However, some specific etiologies do have disease-altering therapies. For example, ATTR amyloidosis can be treated with tafamidis, and hypertrophic cardiomyopathies can be treated with mavacamten. How do we diagnose heart failure and heart failure with preserved ejection fraction? Heart failure is a clinical syndrome characterized by elevated intracardiac filling pressures. So, these patients have a decreased cardiac output at rest or during exercise. We have to have cardinal signs and symptoms in order to diagnose heart failure. Without cardinal signs and symptoms of heart failure, we shouldn't consider it as a differential diagnosis. Main symptoms to look for are exertional dyspnea, orthopnea, swelling, as well as fatigue, lassitude. Cardinal signs, to name a few, are elevated venous pressures, limb edema, dependent edema, as well as creps on lung bases. Once we establish there is a high clinical probability of heart failure, the next logical step is to go for a ejection fraction evaluation and a BNP level. Ejection fraction less than 40% defines heart failure with reduced ejection fraction. If we can firmly place the ejection fraction between 40 to 49, it defines heart failure with mildly reduced ejection fraction. When the ejection fraction is more than 50, we need little more evidence. We should look for objective cardiac, structural and functional abnormalities with an echo, MRI, BNP or N-terminal pro-BNP levels. In the presence of symptoms and signs and normal ejection fraction with typical structural cardiac structural and functional abnormalities, HFpEF is diagnosed. So how do we differentiate HFpEF from other common causes of dyspnea? These researchers have created HFpEF score. This simple tool will aid us in the diagnosis of HFpEF with high degree of probability. So these are the components: heavy, hypertensive, atrial fibrillation, pulmonary hypertension, elderly, and elevated filling pressures. So let's move on to different phenotypes of HFpEF. So most classic form is associated with and is due to obesity. And obesity and insulin resistance induce multiple changes in multiple organ systems, including the heart. In HFpEF pathogenesis, it's not only a comorbidity, it's a root cause of the problem. This is another way to classify heart failure with preserved ejection fraction. The predominant type is the metabolic heart failure with preserved ejection fraction. It has various pathways for pathogenesis: aortic stiffness causing increased afterload, cardiometabolic pathway causing systemic and cardiovascular system inflammation, as well as cardiorenal pathway causing volume expansion and increasing preload. Coronary artery disease associated HFpEF is another type: right heart failure predominant type, AF predominant type, Ockham-like, valvular heart disease, high output heart failure, and other rare causes are other phenotypes. For example, constrictive pericarditis, restrictive cardiomyopathy, amyloidosis comes under rare causes. This is a very interesting study done by Sonia Shah and her group of researchers. They have done a meta-analysis of genome-wide association studies to recognize heart failure associated genomic loci. Here, they have identified recognized cardiac risk factors, for heart failure, and calculated a risk factor for each of these risk factors. So, as you can see, increased body mass index poses a very high risk for heart failure. However, what is interesting, even after statistical correction for coronary artery disease, body mass index associated heart failure risk persists. This contrasts very much with LDL cholesterol associated heart failure risk. When we statistically correct for coronary artery disease, that LDL cholesterol associated heart failure risk disappears. So let's move on to the pathogenesis of heart failure with preserved ejection fraction in its classic and most common form. Obesity is a state of systemic inflammation in the heart. It induces inflammation of the microvasculature, and there is direct and indirect myocardial lipotoxicity causing myocardial inflammation. There is microvascular dysfunction and oxidative stress. This oxidative stress produces cardiac myocyte microfilament activity. There is an impairment, so there is worsened cardiac mechanics. Diastolic dysfunction occurs due to increased intracardiac filling pressures, volume overload, increased afterload, and cardiac fibrosis. There are changes in other systems as well. There is chest wall restriction, reduced vital capacity, impaired ventilation and diffusion, as well as obstructive sleep apnea and pulmonary hypertension in the respiratory system. And in the visceral adipose tissue, there is increased BNP clearance. That is why we may see a curiously normal BNP level in some obese HFpEF patients. These people have a lesser oxygen consumption capacity than normal counterparts. And finally, the liver promotes a generalized inflammatory state. So how does aortic stiffness contributes to this pathogenesis? Aortic stiffening occurs with aging, and it causes increase in aortic systolic blood pressure, resulting in LV afterload, myocyte hypertrophy, causing impaired cardiomyocyte relaxation. There is a decrease in central diastolic blood pressure as well. It causes a decreased coronary perfusion and subendothelial ischemia, leading into myocardial fibrosis. The final result of this is diastolic dysfunction and longitudinal systolic dysfunction of LV long axis, which can be detected by calculating global longitudinal strain on echo. So summarize the pathogenesis. Eventually, there is inflammation of the vasculature, which promotes hypertension, atherosclerosis and atherosclerotic cardiovascular disease, and endomyocardial fibrosis, causing LV hypertrophy. There is oxidative stress impairing cardiomyocyte microfilament activity. fibrosis decreases LV compliance, resulting in stiffening of LV. And in these patients, early stages, there is impaired relaxation of LV, but there is no corresponding rise in LV and diastolic pressures or intracardiac filling pressure. Eventually, however, as the restrictive filling sets in, LV and diastolic pressure increases. There is a systolic failure as well, as I mentioned, in LV long axis in HFpEF. I would like to play some clips to recognize how these various pathogenetic mechanisms causes changes in cardiac mechanics. Hope you can see me. So this echocardiogram shows a normal patient's heart. There is a heart contracts nicely and interventricular septum and posterior wall dimensions are normal. There is no thickening. LA is not dilated. This is another view of the same patient. This shows a LV short axis. You can see heart contracting nicely. Let's compare it with this clip. Here you can see there is a slight thickening of interventricular septum as well as the posterior wall. Patient's left atrium is dilated as well. However, heart contracts nicely. And I would like to contrast the previous two patients with this one. Here, there is a significant interventricular septal thickening, which is asymmetrical. And there is a left atrial dilatation as well. However, heart contracts normally. So how do these various pathophysiologic changes result in heart failure with preserved ejection fraction? What are the changes in cardiac mechanics? This diagram shows left atrial and left ventricular pressures during diastole. And the second pane shows mitral inflow Doppler velocities during diastole. So to summarize the normal cardiac cycle, towards the end of the systole, once the diastole starts, isovolumetric relaxation phase begins, and there is a rapid ready fall in LV pressures. And with that, atrial pressures quickly overtakes the falling ventricular pressures and mitral valves and tricuspid valves open. And there is a rapid ejection of blood from atria to ventricles. We label it as E phase. And this is followed by a diastasis period. There is hardly any filling of the left or right ventricle. And towards the end of the diastole, atria contracts, and then atrial pressures again overtakes ventricular pressures, and second phase of ejection or A phase begins. Here around 20 to 30% of left ventricular filling occurs. The second image shows impaired relaxation pattern. Here you can see the isovolumetric relaxation is prolonged. Heart does not relax normally. So the patient's E phase is prolonged, and contribution of this early phase to cardiac output is decreased. And when we move into the fourth one, you can see as the heart becomes restrictive and stiffened, isovolumetric relaxation time decreases. And there is a increased LA pressure as well. There is a brief, rapid E phase. On the examination also, we can evaluate this. And it is followed by an A phase. Here, in these patients, EA ratio is about 2. These are the diastolic function assessments of about 3 patients. So, as you can see clearly here, these things are demonstrable. The first patient has a normal E phase and A phase, and there is really minimal filling of heart during diastasis, ventricles during diastasis. However, in the second patient who had only slight exertional dyspnea, his EA ratio was 0.6, and his E phase barely touches the baseline and it is protracted. The third patient with hypertrophic cardiomyopathy had a EA ratio of 2.1, and the patient's E face is very tall and brief. So these are the other measurements of my patients. As you can see, interventricular septal dimensions, relative wall thickness, and left atrial volume index all increases as heart failure with preserved ejection fraction and diastolic dysfunction progresses. As well as I want to concentrate on this E to E prime ratio, which increases as well. E prime is the Doppler velocity of mitral annulus, the average velocity of lateral and medial mitral valve annulus. It decreases with progressive diastolic dysfunction and HFpEF. It corresponds well with the left ventricular filling pressures. E to average E prime ratio especially corresponds well with filling pressures. So, what are the structural and functional changes of the heart to look for? So these are the main things: left ventricular mass index, relative wall thickness, left atrial volume index, E to E prime ratio at rest, BNP and NT-proBNP level, and pulmonary artery systolic pressures, as well as tricuspid regurgitant velocity at rest. So if we are in doubt and still there is a high clinical suspicion of HFpEF, we can perform exercise tests such as supine bicycle Doppler echocardiography. A word about BNP and NT-proBNP levels. BNP is a peptide secreted from a stretched out heart. Its levels in HFpEF are typically lower than around half of HFrEF and heart failure with mildly reduced ejection fraction. Obese patients may even have normal BNP levels. So these are the some other types of HFpEF: hypertrophic cardiomyopathy, cardiac amyloidosis, valvular heart disease, chronic kidney disease, AF, and high output cardiac failure. So before coming into conclusion, I would like to note what happened during last 2 decades. These are some trials that shaped our understanding and approach to treatment for HFpEF patients. Charm Preserved is a landmark trial. It compared candesartan versus placebo in patients with ejection fraction more than 40. Conclusion was cardiovascular death and heart failure hospitalization showed a trend toward benefit in patients, but it did not reach statistical significance. TopCat is another trial which compared spironolactone. Here the ejection fraction cutoff was more than 45. Primary endpoint was composite outcome of death from cardiovascular causes, aborted cardiac arrest, and hospitalization for management of heart failure. It did not reach statistical significance for benefit. However, in subgroup analysis, it showed a benefit toward showed a trend toward benefit in patients with lower EF subgroups. Paragon heart failure is another trial which compared sacubitril valsartan, ARNI, against ARB valsartan. There was no statistically significant mortality benefit. However, there was a reduction in heart failure hospitalizations. ARNI benefit was more striking in female patients as well as ejection fraction less than 57% patients. So, an ARNI benefit is proven in HFrEF as well as mildly reduced ejection fraction. In patients with HFpEF, there is a trend towards benefit when the ejection fraction nears 50. This seems to disappear when the ejection fraction rises above 60 to 65. And Emperor Preserved is a very recent and landmark trial. It included patients with ejection fraction more than 40. There was a statistically significant relative risk reduction, and benefit seemed to disappear as the LVEF approached 60. Empagliflozin reduced combined risk of cardiovascular death and heart failure hospitalization in patients with heart failure with preserved ejection fraction, regardless of the presence or absence of diabetes. So, before seeing the future prospects in these patients, I would like to conclude with some closing thoughts. Heart failure with preserved ejection fraction is a very appropriate and timely topic. And we will see an increasing number of patients in the near future as population demographics change. Obesity plays a key role in the pathogenesis. And according to the recent ESC guidelines in 2021, they give class 1 indication for diuretics. In contrast, American Heart Association guidelines in 2022 also give a class 1 indication for diuretics. However, it also includes empagliflozin, SGLT2 inhibitors as class 2A, and ARNI, ARBs, and ACE inhibitors, as well as aldosterone antagonists as 2B indication. And there was modest results from clinical trials until recently. However, empagliflozin diuretics do help these patients. And there are some medications, specific medications, depending on the etiology. For example, for amyloidosis as well as HFpEF. And these patients, however, needs a holistic approach to multiple illnesses they have. So future is bright for these patients as more and more targeted therapies becomes available. So we will be able to approach these patients differently. These are two trials on the horizon. Deliver is we will be able to expect results soon. It compares dapagliflozin in patients with ejection fraction more than 40. And Fine Arts study is still ongoing, and it compares finerenone, aldosterone blocker, in patients with ejection fraction more than 40. These are my references. So, I would like to thank my teachers and colleagues at NHSL Kandy Cardiology Unit. Especially, my gratitude goes to Dr. Srinath Dolapihilla, who is my mentor, and patients who allowed me to obtain these images, as well as especially Ceylon College of Physicians. Thank you.
Thank you. Thank you very much, Asiri, for that erudite talk. It was a pleasure listening to you, and I think you made some points very clear. May I ask whether anybody in the audience has any questions to ask from you, especially the judges?
Yes, sir.
If they want to ask any questions, please.
Yes,
Professor Jayaratna, sir, if you can.
Thank you. That's an excellent lecture. But I would congratulate you on that. But I have just a couple of questions. Now, about this heart failure with specific ejection fraction, what is the role of ACE inhibitors and ARBs in management?
So current evidence supports that when the ejection fraction nears 50, there is a trend towards benefit. It is reflected by 2022 HA guidelines as well. However, this benefit, mortality benefit, as well as heart failure hospitalization benefit, seems to disappear when the ejection fraction approaches 60. Also, if there are other clear indications for ACE inhibitors, such as diabetes with nephropathy or history of cardiac events, they should be given. So there are additional indications we need to consider as well.
Right. Well, the next question I want to ask is empagliflozin, SGLT, glucose transport inhibitors. They of course act as osmotic diuretics. You see,
yes.
So that will help the heart failure. But
yes.
On top of that, is there any additional benefit in the mortality and in the cardiovascular mortality by these drugs, empagliflozin and things? And if so, what is the mechanism?
The mortality benefit, I'm sorry, sir, I can't, I'm not sure about the evidence. However, its mortality benefit cannot be explained only by osmotic diuresis alone. But I can't explain it because more than that, I can't recall the evidence, sir. I'm sorry.
Okay, thank you. Yeah, thank you very much. Yeah.
Dr. Jayanagar, do you have any questions?
Yeah. My congratulations to you, Asiri. Yeah, I'm proud to see you over there. My question is simply, your lecture, I think, highlighted the value of weight reduction more than anything else.
Yes.
So you have, we have sort of like weight reduction drugs in the market. You have any idea how safe are they to be used in the patients with already having HFpEF? Are they safe to be used?
Currently, sir, there are no randomized control trials for weight reduction in HFpEF patients.
Right.
However, there is a recent evidence coming up against GLP-1 receptor agonist. So semaglutide and things like that. So we will see the result in recent future. Safety, of course, there are no specific contraindications for their use in HFpEF patients.
Right.
Likely they are beneficial, but evidence we will have to see soon with semaglutide and the drugs in that group very soon.
Right. Thank you.
Thank
Right.
you, sir.
Thank you, Dr. Jayanagar. There is one question from the audience. I'll direct that also, a brief answer. Is there any specific medicine which can be used in amyloidosis-induced heart failure?
Yes, sir. Tafamidis can be used. It is used in ATTR amyloidosis. What it does is, amyloidosis is a protein misfolding disease. Tafamidis stabilizes the correctly folded proteins. So that's how it helps. Yes. But other types I am not aware. So it's in ATTR amyloidosis. Yes.
Thank you, Asiri, both for the presentation as well as very clearly answering the questions asked, as well as pointing out that some aspects you are not certain of the evidence, so you cannot give a clear answer. Thank you very much for all that. I'm very grateful on behalf of the Ceylon College of Physicians for taking time to join us. Thank you so much. We try to present you with a certificate, which we will obviously email you. I'll try to get it displayed on the screen. Right.
Thank you.
Thank you, Dr. Asiri Gunasekara. All the very best from the Ceylon College of Physicians. Hope you will be with us in the future as well. Thank you.